So we have one more paper before the break, and then we have a new thing, a mini symposium embedded in the program, and the mini symposium is on the enhancement of refractive outcomes after cataract surgery. That's a topic that people ask about a lot. We're going to have a relatively comprehensive symposium on how to enhance refractive outcomes after cataract surgery right after the break. So the final paper, Helen Wu, comparison of ICL to PRK.
Thank you. Thank you for the opportunity to speak this morning. I'd like to acknowledge Dr. Moran for his help with the data analysis for the ICL as well as Star Surgical. I have received an honorarium. The challenge when most of these patients walk through our door is that 100% of them think they're going to get Lasik. But unfortunately, not everybody can or should have Lasik, maybe due to their corneal anatomy, maybe arguably so now, but also due to lifestyle issues. And so how best can we counsel patients on the alternatives to Lasik and make them feel good about it? Well, these are the listed alternatives to Lasik, and this morning I'd like to discuss surface ablation and phakic IOL, specifically my experience with the Visian ICL. So the pros of surface ablation include the fact that it's easy to perform. You can do both eyes on the same day. There's a lower risk of ectasia than LASIK, and it's a corneal procedure, so it obviates the need for intraocular pressure problems and infection. But it is a slower visual recovery compared to LASIK and phakic IOLs. There's usually more patient discomfort early on and a greater risk of corneal infection, and the wound healing can affect the predictability of the procedure. The advantages of phakic IOLs include the fact that it's a very rapid visual recovery and less discomfort than PRK, and the quality of vision is excellent compared to both PRK and LASIK, and I think most importantly in patients' minds, it's reversible. Disadvantages include the fact that usually you need an operating room, and in our center at least, one eye is performed at a time, and there's a greater risk of intraocular complications and a need to monitor endothelial cells and lens changes over time. So when we compare LASIK to phakic IOL in the literature, looking at a large cohort here with Sanders and Vukic, we see decreased stability in the first 6 months of LASIK compared to phakic IOL, as well as less best spectacle corrected vision loss in the ICL group. And when looking at a group of matched controls, we see better predictability, much better, in the ICL group compared to the LASIK group. Visual performance has been looked at in a retrospective study fairly recently and comparing wavefront guided LASIK to ICL, and we see here a decrease in induced higher order aberrations with the ICL compared to wavefront guided LASIK, as well as improvement in contrast sensitivity in the ICL group versus deterioration in the high myopia wavefront guided LASIK group. So there hasn't been much written about PRK and ICL. There was a fairly recent paper by Schallhorn and his group comparing toric ICL to PRK, and that showed excellent efficacy, safety, predictability, and stability in the ICL group compared to PRK group. So I'd like to talk about my individual PRK and Visian ICL results and how I talk to patients utilizing these data. The reasons patients in my center chose alternative procedures, or we chose them, is due to the following reasons, typically thin corneas, irregular topography, or possibly often due to patient preference because of their lifestyle issues or their previous personal research. In the first group, PRK, which I've been doing for 20 years now, there were 74 eyes. I randomly chose 1 year, and at that time we did have 2 separate lasers. The average amount of nearsightedness was minus 4.5, and you can see here that about 60% of the eyes were done on a Vizix laser. Nearly a quarter of them had mitomycin C, which I routinely put on the cornea when the ablation depth is 100 microns or more. Uncorrected vision is about 20/30 to 20/40 in the first postoperative week and improves to 20/20 at 1 year. And best corrected vision drops a little bit at 1 month and then is stabilized to normal at 1 year. We see postoperative stability over time to be quite good after a month with PRK. And the predictability is nearly 80% within a half a diopter and 97% within a diopter at a year, but this is after an enhancement. Best corrected vision, nearly 80% of eyes maintained or gained lines of best corrected vision in this group, and no eyes lost more than 2 lines. The complication rate showed a fairly high enhancement rate, 15%, And this was higher in the LADAR vision group, predominantly because of predominance of overcorrections in that group, and that's why we did the CKs. 2 eyes of one patient had delayed reepithelialization, and another patient had bilateral sterile infiltrates in the cornea. And we had 2 patients who complained of moderate dryness at a year, as well as 1 patient who complained of glare. So in the phakic IOL group, we did have a higher amount of myopia with average -9. These were thinner corneas, 521 microns, and this was a significantly higher percentage of Asian patients in this group. You can see here from the predictability, the attempted versus achieved, that it was excellent even within day 1, and this was maintained at 1 year. And you can see that 83% of patients were within a half a diopter of their intended target at post-op day 1, and 100% were within a diopter, or better, at 78% within a half diopter at 1 year. As expected, there was excellent stability over time. None of them changed by a half a diopter between 1 month and 1 year. And their uncorrected visual acuities were 58% 20/20 on post-op week 1 and 84% 20/20 or better at month 1, and this was maintained over time. In terms of safety, we see that 92% maintained or improved lines of best corrected vision at 1 week. This was also true at 6 months. And there was a loss of best corrected vision at 1 year, and that was due to some patients, a couple of patients with myopic changes in the fovea. We had a 7% endothelial cell loss at 1 year. In terms of complications, 2 eyes had initial pupillary block on the first postoperative day. At 1 year, 30% of eyes still had mild halos, most of which were improved with alpha-GAN. 1 eye actually had a negative dysphotopsia with a temporal shadow. She elected to keep the lens because she knew that it was a reversible procedure. The enhancement rate in this group was 8%, with 4 eyes undergoing PRK and 2 eyes undergoing CK, and our exchange rate was 4% due to sizing issues. 1 patient who was 42 years old, -20, developed visually significant cataracts in about 1 year and had to have cataract surgery, and he had advanced myopic foveoschisis, which caused a loss of best corrected vision. And 2 eyes had visually insignificant changes in their anterior lens capsule, one of which was my first eye that I did. I think the major difference between these 2 groups is that the ICL patients have excellent vision and excellent predictability from the first post-op day on. And you can see that here in this group, in this graph, comparing the PRK results versus Visian ICL. And really, the ICL patients are the happiest patients that I have in my practice, although by 1 month and 1 year, the PRK patients are very happy as well. So in conclusion, phakic IOLs and surface ablation are both excellent alternatives to LASIK. They have excellent visual outcomes and good safety. The phakic IOLs have the advantage in terms of high patient satisfaction from postoperative day 1 and quicker visual recovery. Halos are the primary side effect with the phakic IOL group, but the enhancement rate is significantly higher with PRK. Thank you.
Thank you very much, Ellen.